Thank you very much. First of all, I would like to express my gratitude to the organizers for inviting me and say that I'm really impressed of the organization and of the very welcome event yesterday. So I think that this symposium could become a tradition, and I will really enjoy if every year one other country try to organize such symposium, because it's very important that people working on one topic like us in this hall work together. So I'm a medical doctor from the National Center for Infectious and Parasitic Diseases in Sofia, and I'll present you our research on tick-borne diseases in Bulgaria. 3 bacterial and 2 viral diseases: Lyme borreliosis, Mediterranean spotted fever, anaplasmosis as bacterial, and 2 viral, Crimean Congo, and tick-borne encephalitis. Lyme borreliosis is the most common tick-borne disease in Bulgaria. Recently, this year, we had about 200 cases, but in previous years, we had, before COVID epidemic, we had over 500 cases. And we have Ixodes ricinus spread all over the country. So the whole country is endemic. Lyme borreliosis is obligatory reporting disease in the country. And this is the incidence. You see 2 big peaks 20 years ago, one smaller almost 5 years ago. And these are clinical manifestations according to our previous study on 1,257 patients. So about 2/3 of the patients presented with erythema migrans, and much rare we can see neuroborreliosis or Lyme arthritis. So patients with erythema migrans are mainly with solitary erythema, 63%. And 4.9 with multiple erythema. Then from other clinical manifestation, neuroborreliosis is the most common, much more common than the rest. Altogether, 19% of all cases are with neuroborreliosis, with different kinds. And then we have less than 10% Lyme arthritis, and about 1 and less than 1% heart ocular manifestations, Borrelian lymphocytoma, which is also on the picture above, and then acrodermatitis chronica trophicans, extremely rare, on the picture below. And these are characteristics of our patients. About 2/3 recall tick bite, which means that almost 1/3 of the patients are without anamnesis for tick bite. Just they present with erythema. Median diameter is 11 centimeters, and the mean interval of days after the tick bite onset of erythema about 8 days. Distribution of Lyme borreliosis according to age. We have 2 mostly affected age groups. One is about 5-10 years old children, and the other is people in active age, 45-65 years. And the distribution by month, we have 2 peaks, one bigger, May, June, July, and a second smaller peak in September, which coincides with the peak of tick activity. And these are PCR studies on detection of pathogens in ticks. So ticks from vegetation, not from patients. Ticks from vegetation. So we have 7.3% of the ticks infected with Borrelia burgdorferi sensu-lato, 3.4% infected with Anaplasma phagocytophilum, and about 1% co-infection. And this is species differentiation in ticks from patients, because patients come to our lab with their ticks for testing about the infection with Borrelia in them. So 30% sensu stricto, 25% Borrelia afzeli, 5% Guerini, and also some percentage of double and even triple infections. We conducted recently bird studies to analyze the reservoir role of birds, and we found that some of the birds are very much infected. It goes to big teeth and blackbirds that are 33 to 42% infected. So very briefly about Mediterranean spotted fever. This is the second most common tick-borne infection in Bulgaria. For the last year we have 89 cases with 2 deaths. The number of cases is directly correlating with the number of homeless and domestic dogs, especially with homeless dogs. And the disease is not distributed on the whole country, but only in the southern part, probably because of the Rhipicephalus sanguineus that is thermophilic. And the incidence goes down the same way as Lyme disease for the last 20-30 years. And anaplasmosis, human granulocytic anaplasmosis. The disease was first detected in the US in the mid-90s, and late 90s we published the first report on seroepidemiological detection in patients in Bulgaria, and then we published a tick study and some clinical studies. So I'll show you first the seroepidemiological study. What is interesting here is that out of 145 patients with erythema migrans, 14 were positive for antibodies by immunofluorescence assay of Anaplasma phagocytophilum. It means close to 10% of Lyme borreliosis patients are actually co-infected with anaplasmosis. And then patients with lymphadenopathy after a tick bite, 2 out of 25 were positive, 8%, which is also something typical for the anaplasmosis in patients. And then 1 out of 5 patients with fever, chills, and headache was also positive, 20%, and these actually clinical manifestations are very typical for human anaplasmosis. And even 4% of patients with people after tick bites and no clinical signs after that, they also have antibodies to anaplasmosis. And we also look in healthy subjects population. These were healthy blood donors. 2 out of 70, meaning almost 3% of healthy people are with anaplasmosis, which means that the disease is far more common than we think about. In 101 patients with symptoms after a tick bite, we detected antibodies, and actually among these 24 patients with symptoms after a tick bite, a bit less than half were with erythema migrans, some with fever and erythema. And Crimean Congo hemorrhagic fever. This is a viral disease that is very severe, and the fatality rate is above 20%, 20 to even 50 in some literatures. And we have usually between 1, 2, 3 to 4 cases in the last year. The history started in 1952 with first reported cases. Then in 1974, CCHF vaccines was adopted and started to be produced. Then in 2004 we made first genetic characterization of Bulgarian CCHF viruses, and then of the vaccine strain, and then we did seroprevalence in people, in livestock, and detection in ticks. And I'll show you briefly all these results. We had 4 lab-confirmed cases in this year, detected by real-time PCR. The most important here is that we can detect the virus usually within the first week after the onset of the clinical symptoms. And after that, we can detect only antibodies. We use ELISA tests for antibody detection. So here are the number of detected cases, reported cases for the last 30 years. So you see that they are less than 10, but every year. With one exception, in 2002, we have 54 cases, but this was infection in the hospital. I mean, medical care specialists that were infected from the infected patients, because this disease is very much infective for the person, much more infected than, let's say, hepatitis A. Epidemiological characteristics of CCHF in Bulgaria. Most of the patients have a tick bite, but some are infected through direct contact with livestock or with patients. Active age is the most affected, males more affected because of the professional, and cases occur in usually after springs, I mean usually during the summer from May to August. And the southern east part of Bulgaria, close to the border with Turkey, is affected, but some cases we have in southwest Bulgaria. And although the number of reported cases decreased, the virus expands in previously non-endemic area. Here are in red, the affected, the mostly actually affected areas in the last years. Main clinical symptoms: high-grade fever over 38, 39 degrees, craniopharyngeal syndrome, meaning very hyperemic face and pharynx, malaise, nausea, epistaxis, actually bleeding from everywhere, petechia from all internal organs, and typical laboratory findings: leukopenia, thrombocytopenia, and elevated liver transaminases. CCHF vaccine that is produced in Bulgaria for protection, and CCHF bulin, specific immunoglobulins for treatment. We did 2 CCHF virus seroprevalence in humans studies in 2011 and in 2015. So the first, we actually tested a bit more than 1,000 persons. In the second, 1,500. The first was in about half of the districts in Bulgaria. The second was on all 28 districts. The same test, ELISA, Russian test, vector-based. And in the first, we found reactive samples from 7 districts. In the second, we found from 20 districts. So the first, 2.8% mean seroprevalence. In the second, 3.7%, which is high, especially in the second, which is, better because it's on all the districts. And in some areas, it is up to, the seroprevalence is up to 28%. So here you see the districts that were tested, and actually the seroprevalence, the highest levels of seroprevalence that are specific for the southeast Bulgaria close to Turkey. And you probably know that there is an ongoing outbreak of CCHF in Turkey with almost 1,000 patients per year for the last many years. Risk factors we detected include tick bites, contact with livestock, age over 40 years, and residency in one of these districts in southeast Bulgaria. What we can say, as Anastasia before from Greece said, is that there is another non or very low pathogenic CCHF virus that triggers this high seroprevalence. And we detect actually this pathogen. Seroprevalence in ruminants before that. Out of almost 1,000 animals, cattle, sheep, and goats, from all the districts in the country, we found 18.8, almost 19% seroprevalence, much higher than in humans. And again, the high seroprevalence was in southeast Bulgaria, but you can see in dark blue actually many other districts with high seroprevalence, districts from where we never have cases. So we conducted a tick survey on over 2,300 exotic ticks from the 5 endemic areas in South Bulgaria, in yellow on this map. Among them, over 600 hyaloma and over 100 Rhipicephalus sanguineus. They were tested for CCHF virus Europe 1 or genogroup 5, which is the pathogenic virus. And in addition, over 400 Rhipicephalus sanguineus were tested for Europe 2. This lineage actually is AP92-like that was recently reclassified as IgA virus. So now it is not CCHI virus, it's IgA, it's a different species. And we use for Europe 1, Tachman according to Garrison, and for Europe 2, RT-nested according to Midili et al. And these are the results. For the pathogenic CCHF virus, we found in the endemic area among a mean of 8.6%, but it is between 2.7 and 13.9%, and a mean 8.8 in another district. So let's say about 9% mean for the pathogenic lineage in the very endemic areas. At the same time, for lineage Europe 2, for IgA virus, we found much higher prevalence. This is PCR detection, 40%, which means that this IgA virus is much more common than the pathogenic one, and that is probably because they are very close antigenically. Probably it is the reason for this high seroprevalence without clinical cases. And this is the maximum likelihood phylogenetic tree based on the sequencing of the 200 base pair fragment of the sRNA segment. So from patients and from Hyaloma marginatum, they belong to Europe 1 on the upper part of the graph, and from Rhipicephalus sanguineus, we found IgA virus or serogroup 6 on the graph below. And I will finish with tick-borne encephalitis, this very rare disease in the country. Number of cases are given here, 1 or 2, and not every year. And the map shows, according to ECDC, the geographical distribution of TB in Europe. So you see that Bulgaria is outside endemic area, but still we have a few cases per year. mostly, you know that the tick-borne encephalitis, about us and other flaviviruses, they are mostly asymptomatic, without any symptoms, and the rest are actually unspecific febrile diseases, and only up to 1% are with neurological symptoms. So the cases we detect, 1 or 2, means that at least 100 or 200 cases are in the country. And this is the map showing where we have cases. So in blue dots, you see recently detected in the last years and confirmed cases that are close to our border with Serbia, so have this in mind. And in red and green, actually not confirmed cases in the previous years. And clinical manifestation that we investigated, actually what our patients appear with, is febrile disease with light neurological symptoms, febrile with symptoms of light meningitis, or acute meningoencephalitis. And we did seroprevalence in humans on 1,500 serum samples from all 28 districts. We use ELISA IgG, and we test positive samples with avidity test, and also for IgM in order to, for an instance, detect any recent infection. And this is the result. Seroprevalence is very low. It is mean 0.6% of the samples. Mean avidity index is 60%, but it's between 33 and 85%. And you see where actually we found with the maybe there are some cases in the middle of Bulgaria, some in the north. And this seroprevalence shows that the disease is very rare in the country. So thank you for the attention, and this is the reference lab.